criteria they have seen that if you have done a diagnostic one iodine 123 scan or a iodine 131 whole body scan. So iodine 131 can be used to do a whole body scan also. So we will give a much lower dose. So 1 to 3 millicurie is the normally given. For treatment we give 30, 100 like that. Okay. Uptake is present in some lesion but not in all. So and they have also drawn a hard line that if the patient has not received a single cycle of RIA therapy, then you cannot diagnose RIA refractory. They have put it as a good practice statement. So now I'll go through a case. So this patient had undergone a hemithyroidectomy, PTC, then developed a local site recurrence, and FDG PET was done at the time, no distant metastasis, and had a basically salvage surgery, and this was the histopathology, multifocal tumor deposit, a lot of tumor deposit. PTC dorsal is the main histopathology, largest tumor is 4 cm, basically a high-risk disease already and recurred, and TG is 758 nanogram per ml. So most of us would assume that there may be some bone metastasis at least. So this patient was given 200 millicurie, and this was the post-therapy scan. So you can just see remnant uptake in the neck, and rest are the physiological uptake, no other side. So now what should we do in this patient? Do we do straight away a FDG PET? Do we do some other imaging? So let us see what ATA 2025 says. So this treatment kind of was like an empiric treatment because we did not have a evidence of RIA avid metastatic disease, even though the TG was high. We treated the patient, and the patient only showed a neck uptake, but nothing else. So ATA 22. So empiric treatment is not common, and it's not preferred in our community at all. However, it was a surprise to me that in 2025, ATA has donated quite a lot of emphasis on empiric treatment. So they have mentioned that if the patient has a rising serum TG level, but no disease in cross-sectional imaging, so in case-to-case basis, empiric treatment can be given. And in certain cases, there may be noticeable disease in the post-therapy scan. And if in the follow-up, those post-therapy those diseases that are seen in the post-therapy scan have decreased or shown some response, then the patient can be treated again probably. So much of the references, so when I went through the references in that recommendation, so those are old references where they show that some patients, like 60% of patients may show some uptake in the post-therapy scan, and some 50% of patients may show some poly-TG or some response. However, none of the studies have shown any survival benefit. So I don't think we should consider empiric treatment as a standard of care and only reserve it for a very few cases. So this is the patient. Let us coming back to what happened. So after 6 months, so we have already treated the patient, and there was a PET scan done beforehand. There was no disease, so we kept the patient on follow-up, and we wanted to see what happened after 6 months. So we did another scan. This is completely negative. The remnant is ablated, and the TG has come down, as kind of was shown in some of the papers. The TG would come down even if nothing is seen that much, or probably the remnant is ablated. That's why the TG has come down. So this is a classical scenario, which is colloquially known as TG elevated negative iodine scan. One of the type of radioiodine refractory thyroid cancer scenarios that we can see. So in this kind of thing, we usually will do a USG neck. So USG neck is done for routine follow-up for all thyroid patients. So it shows some suspicious thyroid bed lesion. We also did a FDG PET to rule out if there are any other site at this point. So this is the FDG PET. You can see FDG avid thyroid bed lesions, and this patient underwent FNAC, which confirmed, and then the patient was referred for surgery. So this is the algorithm that we follow. So if we see a tennis where that is TG is elevated but iodine scan is negative, so first we have to rule out iodine interference and heterophile antibody interference. Heterophile antibodies are like anti-TG antibody, but they do the opposite thing. That means they may show falsely elevated values of TG. We do see these things, but we don't have any tests that are available in most centers that can detect heterophile antibodies. So most of these are theoretical. So if you get a thing, get an AUSG done. If it is contributory and operable disease is found, surgery is the treatment. If non-contributory, go ahead with the FDG PET. And if it is operable disease or a localized metastatic disease that can be taken out by metastectomy or ablation or RT, go ahead with it. If not, and nothing is seen, then you can keep the patient on TSH suppression. That is enough. And so let us see another patient. So this is a patient 35 year old initially operated, then with under PTC, underwent 102 millicurie of RIA, followed by LDS negative. After 1 year DA5, patient had a recurrence, underwent nodal dissection. After surgery, the TG is 125 millicurie of RIA, but post-therapy scan showed no uptake. And at that time, the patient has presented with tumor. So, possible reason what can it be? Could it be added interference? Could it be poor resolution of whole body scan? Because we have given a very little activity. Because iodine 131 has a poor imaging characteristic, or interference by heterophil antibody, but there is no way to prove because no assays exist. Or incomplete surgery, maybe nodes have been left behind, like as was being discussed, like some nodes sometimes are left behind, then they come back and recur. And radioiodine refractory DTC, RIDTC. So what can be the next step? So patient was thoroughly counseled about iodine interference and called after 3 months. The TG is now 45, so it has increased a bit. So, and this is the, and we did the scan, again the scan is negative, so iodine interference probability is not. So what should be the next step? Active surveillance, or should we do a FDG-PET-CT because USG is also negative. So we did FDG-PET-CT, but that is also negative. Now, what should we do in this patient? Next step. So this is a classic case of biochemical incomplete response, right? So biochemical incomplete response from the studies of Tuttle et al. And Vassim, and we know that 30% of the patients will spontaneously normalize. So you don't have to do anything. 20% may need some additional treatment because something has been discovered, like some USG neck dissection. 20% will develop structural disease. So the patient was kept on active surveillance and a TSH suppression. And this is the TG level of the patient who had that anti-TG is not elevated and S is stimulated and non-stimulated. NS is non-stimulated because the values are different, right? So you can see that TG level has gone down. So this patient has been followed up for 4 years and the TG levels are normalized. So this highlights that in this kind of setting also, less is more. You have to keep your patients and observe the patient, put the patient, thoroughly counsel the patient and put the patient on active surveillance, and you may see good results. So when not to treat, this is most important than to understand when to